I just got to know we are recording. Front 3 rows need to be filled up. आ जाओ, फटाफट आ जाओ. Last 3 to front 3. आ जाओ फटाफट. क्या इसमें वीडियो भी जाता है?
पीपीटी चलेगा?
हाँ, मेरा वीडियो ऑडियो ही है ना, वीडियो तो नहीं है. Come on, quick guys. Who doesn't understand first 3? Please, first 3, quick. All right, good morning to everyone. Again, I think everyone is awake. The topic for today's lecture is dementia and neuropsychiatric problems. You're not allowed to yawn. My name is Dr. Tanmay. I'm an assistant professor in the Department of Psychiatry. We have Dr. Misbah, who's a junior resident in the Department of Psychiatry. What are the main specific learning objectives from today's lecture? Basically, understand what dementia is and differentiate it from normal aging. Key features of major dementia types, recognize common neuropsychiatric problems and symptoms associated with the disorders, and understand the basic diagnostic approach. I think the main focus of my lecture today is to orient you towards how to go about a person who reports with complaints that are suggestive of dementia. So first, think of dementia as one entity you need to differentiate from normal aging and depression. Why? Because in late life, mental health problems and disablement are most commonly due to depression and dementia. All right, these are the two most common problems that people are going to have in the later life. Prevalence of dementia is going to increasingly increase with age. Whereas normal aging itself is going to cause a decline in the cognitive capacities. I hope cognitive capacities se aap log thode se well versed ho. If someone has any problem, just ask. All right. Overall, we are going to talk about dementia regarding all the cognitive faculties that you have. It ranges from attention and concentration, executive functions, memory, abstraction, judgment, comprehension. All right. All of these faculties together would form cognition. We were talking about normal aging. Normal aging itself is going to dampen the cognitive capacities of any person. And depressive symptoms are more common in the later years of life. So differentiation between depressive disorder and cognitive disorder can be problematic, especially when everything is just beginning. They are beginning to have cognitive difficulties, and you have to differentiate it from normal aging, you have to differentiate it from depression. It's going to be challenging. So that is the baseline one word caveat. It is going to be challenging. No head down, especially if you're in the front row. All right? If you're present in the class, try to pay attention. So, there are many symptoms which can be seen both in depressive disorders as well as cognitive disorders. And depression can coexist with mild cognitive impairment. Now, mild cognitive impairment is a very interesting entity. A lot of attention is being paid to it. It just means there is some cognitive impairment. It is not severe enough to be called dementia. So mild cognitive impairment is a controversial entity, but also remains a useful construct in terms of targeting interventions to prevent dementia. They say that if you catch someone during a mild cognitive impairment, you may be able to prevent it from progressing to dementia. Maybe. All right. What mild cognitive impairment is? It relies largely on a subjective memory complaint as a presenting symptom. The differentiation of early dementia from mild cognitive impairment depends on the level of cognitive impairment and the disability. Wherever you talk about dementia, you are going to have it in your mind that you have to also assess what is the disability arising out of it. Okay? Cognitive impairment in dementia causes significant impairment in instrumental activities. Instrumental activities means activities that require you to apply something. And this is known to increase with time. Most diagnostic criteria for dementia will use the resultant disability as the main important differentiating feature. However, what happens is when a person comes to you with memory impairment, you're going to rely on the informant's information more than the person who's complaining that he forgets, or maybe cannot even complain that he forgets. Okay, so what you're going to do is have an open mind and try to assess all of these complaints in the domain of what is the social context of all of these complaints, what are the expectations of the informant, and what is his or her ability to know the current level of functioning. Do we have an informant who has not even lived with the patient for a very long time? Or do we have an informant who knows the patient before all of these complaints happened and they know how this person used to be and now how he is or she is? So dementia is a syndrome. Syndrome means a collection of things due to disease of the brain. So there is a brain pathology. All of you must have been reading it in the pathology textbooks and lectures. It is usually chronic. It is characterized by a progressive and global deterioration. You don't have any one domain specific deterioration mostly. It's more of a global deterioration. And this deterioration is more in the intellectual capacities like memory, learning, orientation. Someone who started answering said orientation. We'll talk about why orientation is not the only thing. Language, comprehension and judgment. So what is this dementia syndrome? It mainly affects older people after the age of 65. So 65 years is one major arbitrary number, not arbitrary so much now, but 65 years. The prevalence doubles with every 5-year increment in age. So the prevalence that you have at 65 may be 5 times more when you cross 70. I'm not talking about numbers specifically because I don't want it to be a mugging up class. I want you to understand more. This is one of the major causes of disability in late life. Why it is important is because now everyone likes to live independently. In your age, you want independence from everything, from higher authorities, from your parents, from families, this, that. Imagine a point in life where even if you had to live independently, you just couldn't. So this causes a significant difficulty in living independently. There are difficulties in social and occupational functioning, and the disabilities only progress with the severity of dementia. There are cognitive changes that are part of normal aging processes, but they need to be differentiated. Like, this is the message that will keep coming again and again and again. एक dementia है, एक cognitive impairment age की वजह से है. Early stages में differentiating is going to be a problem. And all of these age-related changes that we are talking most frequently occur in 80s and 90s. When a person comes and is in their 80s and 90s, it's going to be what you see. You will also see that a lot of people have transient changes in cognition, only for a brief period of time, maybe a week of it, maybe a few days of it, and then they come back to who they were pre-morbidly. That is one example where orientation cannot be the only thing that you judge about dementia, where you evaluate about dementia. Why? Because these transient losses of intellectual capacity are also very common in an entity called delirium. And the hallmark of delirium is that the orientation takes a toss. All right. So as age progresses, there might be small phases where someone's intellectual capacities are not as accurate, and then they come back also. So delirium is one thing you need to differentiate. How? We'll talk. So how do you evaluate for cognitive symptoms? So cognitive symptoms can be due to many conditions. Dementia is only one of them. First task is differentiate from cognitive disorders. So you need to look for signs and symptoms of dementia, whatever the signs and symptoms of dementia are given in diagnostic criteria. But you have to rule out delirium. You have to rule out depression. Then you have to look for other medical problems. Then you have to assess for the cognitive problems. Then you have to assess for non-cognitive problems. What are the non-cognitive problems? There are some things called behavioral and psychological symptoms of dementia, BPSD. There's a reason dementia is being taken up by the Department of Psychiatry. We're not focusing much on the clinical cognitive aspects as much as we are on the non-cognitive aspects as well. Rule out other mental health or substance use disorders, because whatever happens in dementia, remember the keywords about dementia, it happens in late life, it is progressive, it is chronic. So whatever is happening only for a finite amount of time is suddenly happening only for a finite amount of time, and the person is going back. Think about more reversible causes. Some reversible causes are dementia, some reversible causes are substance use, other you will have medical reversible causes like vitamin B12 deficiency and hypothyroidism and etc. That's a long list. But since we're talking from the Department of Psychiatry perspective, think about all of this. Assess the care arrangements and the need of the carers. This is one disorder in which the person cannot take care in the long run. You have to also assess the person who's bringing the person to you. So the patient is being accompanied by the caregivers, you need to assess the caregiver as well. So what happens when a person presents to you? First of all, there are complaints of cognitive decline. Now you have to check whether there is normal cognitive functioning or not. You will apply some scale, you will probably apply a screener like mini mental status examination or Montreal cognitive assessment or Addenbrooke's. If there is normal cognitive function, this may be normal aging. But if there is impairment in cognitive functioning, then you look for impairment in the activities of daily living. What are the activities of daily living? Anyone? What are the activities of daily living? Getting up, brushing your teeth, having food. If you're a mobile person, you'll go outside, probably go to the market, fetch a few things, come back. So there are basic activities and there are instrumental activities of daily living. Instrumental activities require application of your cognitive faculties. Basic activities of daily living is just like taking care of the basic routine rhythm in anything. So if there is impairment in cognitive functioning, then you look if there is an impairment in activities of daily living. If there is impairment in the activities of daily living also, then you're considering dementia. But if there is no impairment in the activities of daily living, then you're probably considering mild cognitive impairment or depression or normal aging. So this is a flow chart. So far what we've discussed. Does anyone have a doubt so far? Am I going too fast? All right, no hands raised. Now, whenever you evaluate for cognitive symptoms, history taking is the main tool. Because history taking, if you're not accurate in history taking or if you do not know what are the components of gathering history, then you're probably going to make a mistake in assessing a person for dementia. Now, this is common for neurology, medicine or psychiatry. First of all, always choose an informant who knows the patient's current as well as the past functioning. The reliable informant should also be interviewed separately. Sometimes the patient may not let the interviewer speak that freely. So make it a point to also speak with the caregiver separately. All right? Be mindful of the family's culture, values, primary language, the literacy level, and also the decision-making process. Because you need to be sensitive while evaluating for all of this. There will be some details that you will have to ask. And the details are like the mode of onset of cognitive decline, which affects multiple cognitive domains. So what is the mode of onset? Do you know different types of modes of onset? We'll have a session for that at the end of the lecture. What is the pattern progression? क्या चीजें progress कर रही हैं? Right? Clinical manifestations of cognitive dysfunction. What are the behavioral manifestations of it? And what is the overall personality of the person? Is the personality changing as well, apart from cognition? You'll have to ask details like if the person is forgetful about recent events, especially amnesia for events which happened hours or days back. This is the first thing that has to be in your history taking when you're taking the history. Does the person forget the fact that he or she had a meal sometime after having the meal? These are important questions. If you work up a case and come to us for presenting the case and you don't have these questions as a part of your questioning process, not doing a good job. Does the person tend to ask the same questions repeatedly, even though this was answered many times? You'll find that these are the main presenting complaints. But in case this is not a presenting complaint and you are going to assess the person for possible dementia, these cannot be skipped. Is the person unable to recall where they've placed things and often searching for things? If the person does not report, if the caregiver does not report, it should be a part of your questioning. You have to ask if there is a worsening of cognitive symptoms after initiation of certain new medications. As the age progresses, we presume a lot of them have had health difficulties, a lot of them will be on medications, and are the medications coinciding temporally with the onset of these symptoms? It's a very important thing. So you need to ask for details like all the medications the person is using, including over-the-counter products for which a doctor's prescription may not be required. And especially inquire if any of them is of the anticholinergic class of drugs. Now, talking about delirium. Delirium has to be one of the major ruling out diagnoses that you have to screen for. It's an important differential diagnosis of dementia. Patients with pre-existing dementia could present for the first time with superimposed delirium. So a person may already have been diagnosed with dementia, but if they're presenting to you, especially with orientation difficulties, speaking gibberish, does anyone know what delirium looks like when they present to you? All right, no hands raised. So delirium is something that has a rapid onset within hours or days, and the person or the person's family members will usually complain about the disorientation to time, place. The person may be active throughout the day, sleeping or drowsy throughout the day, not so drowsy but super active during the night. So there is a reversal of the whole sleep-wake cycle. There is something called evening worsening or sundowning effect that you see. People are sort of having increase in their symptoms when the sun is setting. So evening times to night times are fairly difficult to manage. So patients with pre-existing dementia can have superimposed delirium when they're presenting to you. Sudden worsening of cognitive functions and appearance of behavioral symptoms should alert the clinician towards the possibility of delirium. Delirium is a medical emergency. Again, a psychiatrist is not required. Your general inquiry as a physician is of utmost and prime importance. If there is delirium, something is medically wrong, 100%. Delirium is always organic. It is never psychogenic. There is no psychogenic delirium. If it is delirium, the person is not oriented to time, place, person. Always think organic. Look behind finding the cause of delirium. A diagnosis of dementia cannot be made if the cognitive deficits occur exclusively during the course of delirium. That is why the importance of delirium. Delirium is characterized by a disturbance of consciousness and a change in cognition that develop over a short period of time. So, mota differences kya hai? Onset is usually abrupt for delirium, insidious and progressive for dementia. Comparative features kya rehte hain? Duration, usually hours to days, but dementia is chronic and progressive like we saw. Attention, reduced ability to focus, but you don't see so much of attentional problems in dementia. Consciousness, awareness, this is what is fluctuating in delirium. A person may be oriented and conscious for a few moments of the day, maybe an hour or so, but that may be fluctuating. That is why I said, in the daytime they may appear as oriented, conscious, everything, nighttime not so much. Similarly, differences in speech, they'll have some incoherent and irrelevant speech in delirium, usually coherent in dementia. There's no speech problems that way. There may be a little bit of aphasia in dementia, but not a speech problem. Cause, there's always an underlying medical cause like substance intoxication, side effect of a drug, or maybe some infection, maybe some pain, understimulated, overstimulated environments, recent hospitalization, prolonged hospitalizations. All of these are risk factors for delirium. But dementia, it has a clear neuropathological basis, so you've studied that in pathology. Other features are a person may be very hyperactive active during the phases of delirium, may also be very hypoactive during phases of delirium, likewise. But in dementia, there is no rapid change of symptomatologies. Now, what happens when there are symptoms that are possibly psychotic or schizophrenia-like? So, dementia people may also have this set of symptoms. So, the key differentiating features are the history. For dementia, you will have a history of progressive cognitive decline and a history of that cognitive decline preceding the onset of schizophrenia or psychotic-like symptoms. Fairly easy. You ask, ye pehle aaya tha, wo pehle aaya tha, and you fairly understand. It could be difficult when psychotic symptoms have onset after the age of 60 years. So, also in situations where it is difficult to test cognitive functions because psychotic symptoms are interfering with the assessment of cognitive functions. So, one could also come across individuals who after many years of illness with the onset during adulthood, either schizophrenia or bipolar disorder, that means a psychiatric illness, can present with cognitive decline and clinical features suggestive of dementia. So, chronic schizophrenia, chronic bipolarity also leads to some dampening of cognitive reserves, cognitive faculties. But so does dementia. This may be a challenging process. In such diagnosis and in such situations, an additional diagnosis may be given that he has a psychiatric illness as well as dementia. All right. due to pre-existing health conditions. So, clinical features that differentiate psychosis from dementia, psychosis of Alzheimer's disease or dementia versus that of schizophrenia. So, there may not be a lot of bizarre or complex delusions in psychosis due to dementia, but in schizophrenia that may be frequent. Misidentification of caregivers is very frequent in the psychosis that happens in the context of dementia, but it is not usually seen in schizophrenia. Common forms of hallucinations are mostly visual when there is dementia, not so much in schizophrenia. You get visual hallucinations, but they always prompt you to go organically, do an organic workup, find out. Common, the first rank symptoms. Have you had psychiatry classes in the past? Anyone aware of the first rank symptoms of schizophrenia? You've had your classes, all right. So these are the main differentiating features. You'll have a past history of psychosis in schizophrenia, not so much in dementia. Active suicidal ideation usually is not complained in those people with dementia, psychosis in dementia compared to schizophrenia. There's a need for long-term treatment with antipsychotics. That is for schizophrenia, not so much in dementia. In fact, do you know there is a black box warning for antipsychotics? Black box warnings mean it's a serious thing. Any person who is elderly and with dementia, do not give antipsychotics. That is a black box warning because it leads to increased rates of deaths. That's what the black box warnings say. Now, there was another entity called mild cognitive impairment, and you need to differentiate mild cognitive impairment from dementia as well. So, mild cognitive impairment will have impaired cognition in one or more domains, but to a lesser degree than in dementia. So, it's all a relative thing now. We are looking at it across the spectrum where there are decreased severity of symptoms versus increased severity of symptoms. And what is the severity in dementia? Dementia में severity ऐसा देखा जाता है कि जब mild symptoms है तो बहुत ज़्यादा assistance की ज़रूरत नहीं है. जब moderate symptoms है तो थोड़े बहुत assistance की ज़रूरत है. और जब severe severity है तो बिना assistance के काम नहीं हो सकता. So keep that severity levels in mind. If dementia is mild, assistance may not be required. If it is moderate, frequent assistance may be required, and if it is severe, then full-time assistance is required. So, if there is mild cognitive impairment, there might be mild impairments in the more complex aspects of daily functioning, and if it is dementia, there is substantial impaired cognition. There is no significant impairment in the activities of daily living as well as long as it is MCI, but there is sufficiently severe to interfere with daily activities of living. So clinical features may be difficulty in solving complex problems, difficulty in performing more than one task at a time, and dementia mein to there will be severe memory loss, there will be visuospatial dysfunction. Has anyone encountered a patient with dementia? Ever? You've been going to medicine clinics. Have you ever encountered any patient with dementia in your neurology rotations? Anyone? Not yet. All right. Language problems, articulating problems, personality problems, all of this can happen. So prognosis, do we say that the person is going to live a good enough life, not so good enough life, or what? So prognosis in MCI may represent a prodromal state of dementia. However, not all individuals having MCI will go and progress to dementia itself. But if a person has dementia, then you can at least prognosticate that this will only progress with time, if not intervened. So the overall flow chart. Now, if you have not paid attention to any part of the lecture so far, now we are going to have a series of flow charts. At least you'll organize your thoughts well enough to understand how to proceed if a patient comes to you. So they'll be presenting symptoms whenever the patient comes to you. There'll be cognitive decline, usually problems with memory. Memory problems are usually the first things that alert someone. Severe forgetfulness. Examples have already been discussed. Do they have food and then forget that they've had food? Do they go to the washroom, forget that they've been to the washroom, spoken about one thing but then coming again to you and speaking about the same thing again as if you're speaking for the first time on the topic, but it has clearly been discussed just a few moments earlier, things like that. If there are mood or behavioral problems in a person advancing with age, 65 and above, and the problems are specifically apathy or irritability, आजकल फ़र्क ही नहीं पड़ रहा है किसी चीज़ का, या बहुत चिड़चिड़े हो गए हैं या हो गई हैं. लॉस ऑफ इमोशनल कंट्रोल, गेटिंग अपसेट ईजिली, इरिटेबल, tearful, problems in carrying out usual work, domestic or social, either. So a lot of people have a lot of aging population in their families. If you pay attention to what are the problems that are happening to them, you might be able to clearly try and get it in your head. Is this something I would classify as a part of normal aging? Is this something I would classify as a part of probably mild cognitive impairment? Or do the signs or symptoms appear to be that of dementia? Think. After this class, you should be able to at least think in that domain. An elderly person from your family or from your neighborhood or a friend of a friend's family, whatever. You hear a symptom, it should automatically come to your head. Where do I categorize this? What is the next question I need to ask? What is the next question I need to tell him to ask in their families? And this is how you can at least alert someone who can timely come, get recognized, if possible, arrest the development of progression. It was planned to insert a video doing this, but some technical glitch happened. So, if there are presenting symptoms like all of these, then you look for impairment in the activities of daily living. If there is no impairment in activities of daily living, then dementia is somewhat out of the picture. Alright? Look for any other mental health conditions like depression also. So you may have a person who's complaining of memory difficulties or complaining of not being able to work as well as they used to work before, but there is no significant impairment in daily living. Probably not dementia. Think of anything else, not dementia. But if it impairs the usual activities of daily living, then think about dementia. Alright, so in case you are suspecting dementia, then ask about activities of daily living like handling of money, taking medication by themselves, cooking. These are all instrumental activities. Personal health and hygiene, these are all instrumental activities. And if there is a significant impairment, then you need to think about doing a further assessment. We'll come to it in the next slide. Now you have to consider other explanation for cognitive symptoms. Are the symptoms gradual in onset and slowly progressing for more than 6 months now? Yes. If yes, then does the person have moderate to severe depression? This is for persons where daily impairment नहीं हो रहा है. जहाँ पे daily impairment हो रहा है और यहाँ पे gradual onset 6 महीने से बहुत ज़्यादा बढ़ा हुआ है, तो ask कि बीच में abrupt onset या short duration तो नहीं रहा है. अगर short duration abrupt onset रहा है, think about delirium. If no, think about depression. Try to rule out depression. If you can rule out depression, then you suspect dementia. If depression is there, then you assess for depression and manage for depression. If you're suspecting delirium, then again, find the cause for delirium, treat the cause, delirium will go away. Alright? Now, again, ask yourself, does the person have any of the following? If the person is less than 60 years, prior to the symptom onset of symptoms associated with head injury, stroke, altered loss of consciousness, अगर ये सब रहा है, look for clinical features of hypothyroidism. So, whenever you are assessing someone, ऑर्गेनिक वर्कअप तो साइड बाय साइड चलना ही है. साइकोलॉजिकल वर्कअप में डिप्रेशन जरूर देखना है. ऑर्गेनिक में सबसे पहले डिलीरियम देखना है, डिलीरियम रूल आउट करना है. इफ यू आर सस्पेक्टिंग ऑर्गेनिक, थिंक अबाउट हाइपोथायरॉयडिज्म. इफ हाइपोथायरॉयडिज्म इज देयर, फिर डिटेल्ड मेडिकल न्यूरोलॉजिकल इवैल्यूएशन करते रहो. इफ यू नॉट सस्पेक्टिंग हाइपोथायरॉयडिज्म, डज द पर्सन हैव पुअर डाइटरी इंटेक? If the person does have dietary intake that is poor, that can be categorized as poor, go for nutritional supplementation, assess him that way. अगर ये सब भी नहीं है तो फिर हाइपरटेंशन है क्या, हाई कोलेस्ट्रॉल है क्या, ओबेसिटी है क्या, हार्ट डिजीज है क्या, ये सब नहीं है छोड़ दो. अगर है तो उसका स्पेसिफिक मैनेजमेंट करना शुरू कर दो. बिकॉज अगेन रिवर्सिबल कॉजेज, इरिवर्सिबल कॉजेज. इरिवर्सिबल है, डिमेंशिया डायग्नोज हो गया तो क्या करना है, वील डिस्कस. बट इफ इट इज रिवर्सिबल, इफ दीज आर वन ऑफ द मोस्ट कॉमन फैक्टर्स लाइक either delirium or hypothyroidism or a nutritional deficiency or hypertension or a cardiovascular risk factor or high cholesterol, appropriate management. All right. Now, what are the behavioral and psychological symptoms of dementia? Persons when they present to psychiatry OPD, referred by the medicine, the physicians, the endocrinologists, the neurologists, then you look for behavioral symptoms. What are the behavioral symptoms someone can have if they're having dementia? They can have wandering. घर से निकल जाते हैं, लोगों को लेके आना पड़ता है वापस घर. They forget their way back to the home. Nighttime disturbances. They are the most fidgety, restless, and not sleeping during the night time. There may be episodes of agitation, there may be aggression outbursts, and psychological symptoms like hallucinations, delusions, someone is stealing my things. One of the most common delusions that you may find in these people when they present to the OPD is that someone is stealing my things in the home. But what is the core central feature that's going wrong? They're forgetting where they're placing things. But that develops into a delusion that people are actually after me, and they start collecting and hoarding everything and keeping them in front of their eyes. Okay, this is one of the most common things that happen. There is anxiety, there is uncontrollable emotional outbursts, there may be a lot of ready tearing up that may happen. So, if there is dementia but no behavioral and psychological symptoms, then the first thing you need to do for dementia is provide education to the person as well as caregivers. Encourage interventions to improve cognitive functioning. How can you improve cognitive functioning? Involve them in very structured daily routines. Keep everything in front of them. Reduce the complexities. Let everything be in front of them clear. Calendar, clock, bed made properly, no convoluted ways in the house, very straight functioning. And support for caregivers. At certain point of time, you may need to consider medications also. But we are not talking about medications must. If there is dementia with behavioral and psychological symptoms, protocol 1 only means that behavioral and psychological symptoms को सबसे पहले तो without medications manage करने की कोशिश करो. Target each and every symptom that they are reporting and try to do it non-pharmacologically. Only if you cannot control a thing non-pharmacologically, you go to the pharmacological measures. So, what are non-pharmacological measures? Alright, there's one more slide and we'll go then to it. If the clinical condition is stable, then continue the current management plan, follow up every 3 months. Because it's a chronic progressive thing, you don't need to follow them up every week or month or so. You can follow them up every now and then. But if not, if the person is not improving for the behavioral and psychological symptoms with non-pharmacological measures, you need to call them again, try to give medications for a short period of time, control that specific symptom and then assess again. So far, we've talked about what dementia is. It's a disorder of the brain. It's not a disorder, it's a disease of the brain with many symptoms, so many symptoms that it can be called a syndrome. It is chronic and progressive. It has a neuropathological basis of it. At the same time, there are many disorders that may mimic dementia. The most deadliest of them is delirium. If you do not treat delirium, it may result in premature death. And it always has an organic cause, so do a good workup when they are presenting with orientation problems. At the same time, look for other medical causes like hypothyroidism, nutritional deficiencies, any chronic health conditions and treat that appropriately. If it is dementia and it has severe impairment, then look, do they have a lot of behavioral problems and psychological problems? Behavioral problems like a lot of agitation, nighttime disturbances, wandering away from home, or psychological symptoms like being deluded, having a lot of hallucinations. Treat. How do you treat? Psycho and social interventions. That means without medications, the interventions that you can do is first of all provide information and education to the caregivers, because caregivers are the only person around them that can look at the world from a bird's eye view. The caregiver is supposed to know everything about the disorder. Simple explanations dene hain. Key messages that need to be communicated to the caregivers and family is that dementia is an illness of the brain, usually tends to get worse with time. Most conditions that cause dementia are irreversible and therefore complete cure may not be possible. We can do many things to help the person and the family. Guidance will help address issues that arise during the dementia care. Now, the main focus when a person comes to you, has dementia, is on the medications for dementia. Does anyone know the medications that they give for dementia? Usually? 1 or 2 medications you must be knowing. A little louder. A little louder, come on. Donepezil, memantine. You want to increase the acetylcholine in the brain. So, some people are there, they are getting the medications, yet there are a lot of psychological and behavioral problems. So, what do we do? Our overall aim is कि ये अपना काम थोड़ा बहुत करना जारी रखें. So, for a person who has lost the ability to even know that he is forgetting things, what do you think is going to help in their day-to-day activities? You make their routine very simple and you do not place anything in their vicinity that leads to complication. So, clothes arranged properly, all things that they have of emotional significance and remember have to be placed in front of them. Old photographs, clock, date. So that time, date and old pictures are there for them, readily accessible, readily available. Pathways, the movements around the home do not need to have any obstacles. So if there are any obstacles that may lead to increased risk of falls, you remove all of them. If they have any outburst of emotional crying, for say agitation, anger, most of it is in response to something that they're not getting or something they're not able to convey because they may have aphasia, etc. also. Just be next to them, comfort them, console them, that's all that we can do. Alright. There may be some interventions where cognitively we are able to stimulate them. So there are some activities like music, sound, engage them in daily routine that starts with yoga, provide them meal that is adequate in nutrition, give them proportionate meals all throughout the day, and make sure that added complications do not occur. Medications need to be checked, medications need to be supervised, and then there are some cognitive stimulating therapies, CST. That sort of therapies can be given by clinical psychologists or any other social worker that's around, and caregiver needs to be sort of addressed, assessed, and comforted. The next thing comes that after you do all of this, also if the patient's behavior is not under control, then there are some certain sets of medications that you can give for a small amount of time. Does anyone know the medications that we can give to control behavior despite having a black box warning for it? I've given you a big hint. Antipsychotics. Low dose antipsychotics are being given for a very short time to control the behavior that arises out of the demented faculties of the brain. Short-term duration of antipsychotics. If the person has depression, then there are some very specialized ways of assessing for depression. Has anyone heard of a scale that is made only for assessment of depression in dementia? Anyone? Well, this is not MBBS level stuff, but still. All right. Any other scales that you know for assessment of depression that may be used for people with dementia? Because irritation, apathy, not engaging with family members could also be a resultant of the depression that is setting in the context of dementia. If you treat depression, you may be able to change their behavior. Does anyone know how to assess it? Have you heard about the Montgomery-Asberg depression rating scale? Not yet. MADRS? No. Well, Cornell has made a scale only for depression and dementia. So it's the Cornell scale for depression and dementia, CSDD, that is used for it. And then if it is depression, give antidepressants. If it is agitation, hallucinations, delusions, low dose of antipsychotics. Does anyone know an antipsychotic that has been approved only for dementia? The antipsychotic that has been granted by the US FDA to give for psychosis and dementia. Anyone? Come on, pharmacology 101. Rispe don't know. It's a recent molecule. If you've heard, you've heard. It's pimavanserin. Okay? And it's available in India now. We're giving it to our patients over here. Pimavanserin. The unique thing about this antipsychotic is that it does not directly act on dopamine receptors. So you don't have extrapyramidal symptoms. What are the antipsychotics you would prefer in a person with dementia if you don't have pimavanserin? Any antipsychotic with a low EPS potential. So quetiapine, olanzapine. The penes have a lower risk of EPS. So you may think about them. So this was an orientation into how to assess, think and proceed with a person who's coming to you with psychological problems, behavioral problems, and having a diagnosis of dementia. If you're not clear about the diagnosis, how to proceed, how to rule out the other causes of dementia is something that we briefly spoke about. Are there any questions for the class? because we have 15 minutes and I'll now start some interactive processes. So if you don't have a question from yourself, then I may pick any one of you to ask some things. And I want to make sure you've heard. If not heard, then you hear it for the first time again. Any questions so far? All right. The last bench. Yeah, next to you. Yeah. Name any one reversible cause of dementia. Any one reversible cause of dementia. Please be a little louder. Can't hear you. What's he saying? Hypothyroidism. All right, good enough. Right, yes, you. Yes. Name any two behavioral symptoms in dementia. Yes, you. Yeah. Any two behavioral problems you may see in dementia. You can sit down. You may see wandering. You may see apathy. Okay, sit down. Sit down. Sit down. There is one thing I did not touch in the whole class because you may go through it in the medicine lectures. What are the different types of dementia? Anyone who has read it in the past? Yes, I see you nodding. So if you can just name a few types of dementia, the names. Alzheimer's dementia. Unfortunately, Parkinson is not a type of dementia. Parkinson is a movement disorder. Okay, so this is a very common thing that medical graduates usually confuse with. That's why I'm asking it. Parkinson's is a movement disorder. In Parkinson's, the main issue is the person is not able to walk properly. Okay, it's a movement disorder. It comes under a constellation of movement disorders. So you will have Parkinson's disorder, you will have progressive supranuclear palsy, you will have corticobasal degeneration, many things. It's a constellation. Parkinson's is one of them, not Parkinson's. So apart from Alzheimer's, what types of dementia do you know? All right, sit down. Thank you for volunteering. Anyone else who knows any other type of dementia apart from, very good, batao. Lewy body dementia. Sit down. Very good. So Lewy body dementias are there. What other types of dementia do you know? Okay, so I'll give you a brief thing on that. There are some dementias in which memory is not an issue at all. Memory is intact, but you have a lot of behavioral problems. Okay, and that is called frontotemporal dementia. You go for neuroimaging, you may find cortical thinning in the frontal region and the temporal region. But it's something that usually does not turn up in each and every time you go and scan a person with that. But the main features are that there are a lot of personality changes in these people. And the onset is usually earlier than what your normal dementia onset age is. So frontotemporal dementia people are one of those who come to the psychiatry OPD a lot because they have sudden personality changes which are very much interfering in their daily activities. Sudden onset crying, sudden onset anger outbursts, unusual demands, very persistent with their bizarre demands. And you might even be able to make out a diagnosis, a psychiatric diagnosis out of it. But since the age at onset is fairly late, you're always thinking organic. So frontotemporal dementia is one, जहाँ पे memory problems इतना impair नहीं करते, पर psychological behavioral problems, personality changes बहुत ज़्यादा impair करते हैं. I want you to orient yourself to one more category of dementia, which is vascular dementia. All right. Vascular dementia also is one sort of dementia that arises because you have a lot of vascular risk factors. You may have a cardiovascular thing, you may have a cerebrovascular history, accidents history, cardiovascular accident history, you may have very deranged cholesterol levels, and vascular dementia also can be made out by having a sequence of MRIs and CTs and some blood tests, etc. Frontotemporal dementia is very important for you to know. Lewy body dementia is very important for you to know. There are other infective things that can cause dementia. Does anyone know any other infections that can cause? Yes? What? Creutzfeldt-Jakob disease. Very good. Prions, Creutzfeldt-Jacobs. HIV. When a person progresses to the level of AIDS, AIDS may also lead to dementia. So you should orient yourself to that as well. Anything else? Any other causes of dementia that you may know? So nutritional causes we all know. Vitamin deficiencies definitely may predispose to dementia-like features, although correctable. Hypothyroidism, fluctuating cholesterol levels, having a previous history of cardiovascular accidents, cerebrovascular accidents, any head trauma. These are things that you need to ask in history. All right. You, medications that are given for dementia. Yes, you, second bench. Next to you. So, any medications that you may know that are given for dementia? Someone has already answered. Bolo, bolo. Not heard of memantine, donepezil, galantamine, rivastigmine. Not heard of things like that. All right. So, donepezil and memantine, two drugs. So, these are the basic things about dementia that you need to know. When to give, why to give, donepezil, memantine, we leave it to the medical faculties to teach you. I wanted to orient you that if there are psychological and behavioral problems, think about it being a frontotemporal dementia variant. Second thing, rule out depression. Third thing, rule out psychosis. Fourth thing, if you have to give medications, at least be clear in your class of drug to be given. If you're giving antipsychotics and if the candidate is good for pimavanserin, think about pimavanserin. If not, low dose antipsychotics like very low dose of risperidone, but avoid. Go for quetiapine, aripiprazole, low EPS potencies. If the person is depressed, give antidepressants. Some people also use mood stabilizers, anticonvulsants. Anticonvulsants are also being used as mood stabilizers. So you may sometimes give sodium valproate, maybe oxcarbazepine, but all of this comes with a lot of risk. Do not give if you do not have expertise or if you've not observed cases for the things that you need to monitor them for. But broadly speaking, these are the classes of drugs that you may use. So we'll have attendance now. Dr. Misbah will ask for attendance. And if there are any questions, you can just walk up to me. Finishing a lecture in 40 minutes does not leave us to discuss each and every aspect of dementia, but at least you're oriented to it. That was the main purpose. So I'll ask all of you to call out your roll numbers and stand up one by one. We'll start from the behind. So, yeah. Louder when you're speaking your roll number, nahi? 18 and next.